Hello, I'm Barbara McLean, and welcome to the series Quick Look in Shock Syndromes, a quick way for us to evaluate patients in shock and gather our data together so that we have a good idea about what's occurring for our patients. And so, to begin, we always want to remind ourselves that shock is always an issue of circulation. Whether that problem is because we don't have adequate volume, we have a poor heart, we have altered vascular tone, it's always about the inability of the blood flow to meet the metabolic demands of the system. So we've talked a lot about hemodynamics, we've talked about stroke volume, we've talked about base deficit. Hemodynamics, stroke volume, and base deficit are all going to be applied here to help us understand how to evaluate and treat patients with shock. So we remind ourselves that tissue hypoperfusion is the common denominator for all forms of shock. And typically it's because you have a low blood flow state or because blood flow is maldistributed across vascular systems that are overdilated or overconstricted and not actually achieving the effective blood flow delivery that promotes cellular health. All right, before we do that, we need to once again review some basic terms that help us in diagnosing shock. So we start with preload. Preload, as it was originally understood, was the stretching of the muscle fibers when the chamber was filled with volume. Now we're talking about ventricular volume. So as the ventricular fibers are stretched, when filling of volume in the ventricles occurs, that is called preload. Now we can't look at volume load, so we use preload pressure, and what's most common for us in the ICU today is to utilize central venous pressure or right atrial pressure, not as a volume indicator, but as an indicator of the compliance of the right ventricle and right atria as those chambers are filled with volume. If you have a healthy ventricle, a lot of volume will not cause an increase in preload pressure. But if you have a stiff ventricle, a non-compliant ventricle, a pulmonary embolus, obstructing outflow, small amounts of volume will cause a significant increase in pressure. So we talk about preload pressure, and that is volume and the compliance of the chamber being filled. Really essential for us to understand. Afterload is a measure of tension that the ventricle must generate to overcome resistance. For the left ventricle, that resistance is in the aortic valve and in the arterial bed and ultimately to the venous bed, as we discussed in hemodynamics. We talk about afterload as a calculation known as systemic vascular resistance. Systemic vascular resistance is an expression of how difficult it is for the heart to mobilize blood volume across a resistant or non-resistant compartment. And the heart has to work intensely, has to develop a very extraordinary amount of tension against both vasoconstricted states and vasodilated states. So always important for us to remember that afterload is the resistance to flow and also is representative to how clamped or dilated your blood vessels are. Now, we've talked a lot about cardiac output and cardiac index, and it's important to remember that cardiac output is the amount of blood ejected from the ventricle in 1 minute's time. So there's two important components, the amount of volume ejected per beat and the amount of beats you have per minute. Stroke volume times heart rate equals cardiac output. Now that actually gives us a very nice indicator of your blood flow dynamics, but the most important factor here is your stroke volume because that's the one that gets limited or elevated in critical shock states. Cardiac index is the dividing of cardiac output by the body's surface area, which is a much more meaningful measure than pure cardiac output because it tells us about blood flow dynamics to the size of the patient. Vascular resistance, as I mentioned before, is really our afterload measure. And we talk about this as systemic vascular resistance being the resistance to LV ejection, and pulmonary vascular resistance as being a reflection of the right ventricle's ejection. Now, many of the drugs that we administer will affect preload, afterload, SVR, PVR, and of course, ultimately, cardiac output and stroke volume. And finally, the most important component that makes it the simplest for us when we're evaluating patients is tissue perfusion measures. So in general, lack of tissue perfusion is measured as metabolic acidosis. And we correlate that with the base measures. Remember that normal base is 0 plus or minus 2. So a base in deficit means an acid in excess. A base in excess means an acid in deficit. Very good. And our venous value, our venous blood gas sample, normal PVO2, venous oxygen, is normally 45 or around 45 to 55. And by the way, if indeed your venous PO2 drops below 37, your patient's in shock. So this is a really important criteria that can help us diagnose our patient. In addition to that, we have measures that help us to understand the adequacy of delivery of oxygen and the tissue utilization for oxygen. That requires a central venous or mixed venous blood gas. SVO2, mixed venous, is blood gas that's drawn from the pulmonary arterial distal port. SCVO2 is a blood gas drawn from the distal port of the central line. And both of those are beyond what we're going to talk about today because this is a more complex advanced hemodynamics indicator and it requires more time than we have available. So we're really going to focus today on your base deficit. All right, the last of the basic concepts is cardiac output. Remember the amount of blood ejected out of the ventricles each minute. Normal is 4 to 8 liters per minute, and the index of that with the body surface, normal being divided by the body surface, the normal index is 2.5 to 4 liters per minute to meter to the 5th power. Now remember, if you know me, you know I'm much more interested in stroke volume, which tells me about ventricular efficiency. Stroke volume is the amount ejected by the ventricle with each contraction, and it really gives us a significant overview of ventricular efficiency, volume load, contractility, and ability to overcome afterload. So we love, love, love to look at stroke volume. SVR, remember, is the calculated indicator that tells us about tension. And I want to remind you that the calculation for SVR is MAP, beginning of circuit, minus CVP, end of circuit, divided by blood flow, cardiac output. And that answer then is multiplied times 80, which converts it into dynes, which is a resistance measure. Normal SVR, 800 to 1200 dynes per centimeter to the 2nd power. Increased SVR means that you have poor stroke volume and you're vasoconstricted. Decreased SVR means that you have high stroke volume and you're vasodilated. So SVR greater than 1200, vasoconstriction with poor stroke volume. SVR less than 800 means that you have a high stroke volume with vasodilation. So we like to talk about these numbers like they are the end-all and be-all, and they are very good drivers of decision making in terms of whether you should get volume, inotrope, or vasopressors. And that's really the key to understanding shock. Always remind yourself that cardiac output and SVR are inversely related. So if cardiac output, particularly stroke volume, is up, SVR will be down because of the calculation. If cardiac output is down, SVR calculation will be up. So one of the first focuses when we talk about shock is if we know a low SVR, we're going to look at that cardiac output and we're going to support the cardiac output, and then we may actually cause some vasoconstriction. If the cardiac output is low and the SVR is high, we're going to support the cardiac output, and then we might apply some vasodilation. What's really important to appreciate is cardiac output, both the heart rate and the stroke volume, as well as SVR, will change significantly before your blood pressure drops. By the time your blood pressure drops, we have already missed some early signaling in shock. Okay, so last but not least of basic concepts is stroke volume. Normal stroke volume, 60 to 100 mLs per beat. Stroke volume is a very primitive relative of ejection fraction, but what stroke volume tells us about is ventricular efficiency. That means if I give you volume, your stroke volume should go up if your ventricle is efficient. If I give you inotropes, your stroke volume should go up if your ventricle is responsive. And if I give you vasopressors, I would like not to titrate vasopressors so high that your stroke volume goes down. My whole purpose is to support your stroke volume to provide adequate blood flow. Now we can also look at stroke volume index. That's indexed to your body surface area, so that's stroke volume divided by body surface area. And normal stroke volume index, 25 to 35 mils per meter square. All right, we love that stroke volume. It's comprised of those three things I've already talked about: preload, afterload, contractility. Preload, the true preload measure, is the volume of the ventricles at the end of diastole and the stretch it places on the muscle fibers. We measure it as pressure. True afterload is the tension of the ventricles to overcome the resistance in order to eject its volume of blood, and we use calculated SVR for the left heart and calculated PVR for the right heart. And contractility is a nebulous thing indeed. It is just the force with which the heart muscle contracts. We can't really measure it, but we assume it by stroke volume. Most important is stroke volume. So if I have no other methodology, I'm going to assume stroke volume by looking at systolic pressure. I'm also going to assume it by looking at pulse pressure, which is systolic pressure minus diastolic pressure. Remember, that's 35 to 45. Okay, very good. So we've got all our indicators in our mind ready to go. And you want to remind yourself that all your therapies are ultimately about increasing your stroke volume and decreasing your heart rate, maintaining an adequate cardiac output, but doing it with ventricular efficiency. So the three big problems that we talk about with shock. Number one, most common, inadequate volume. That's hypovolemia. You have a low total volume, you can have a low arterial volume, you can have venous pooling, you can be wasting fluid insensibly because you have a burn, or you've got a fever, you've got rapid respiratory rate, you've hemorrhaged, or you have profound pooling of volume like in the abdominal compartment. You have extravascular volume but not intra-arterial volume. Number one cause of shock, inadequate volume. Number two, but not necessarily the second cause of shock, is an inadequate heart cardiac output. Don't have volume in the veins, so you've got hypovolemia, you have a poor cardiac output. You can fix that with volume, but you also can have an inadequate cardiac contractile strength. You're not going to fix that with volume, and you don't fix it with vasopressors. That patient needs an inotrope. An inadequate heart rate. We have sinus exit block, we've infarcted around the sinus node, around the AV junction, we're in AV dissociation. We don't have an adequate heart rate to maintain an adequate cardiac output. But we also see inadequate cardiac output when the heart does excessive work. Excessive work occurs when we have hypertrophy, when we have hypertension, when we have an overabundance of vasoconstrictors on board. We now have a heart that cannot eject against that constricted vascular space. And last but not least, inadequate vascular tone. Inadequate vascular tone means that your small arteries and capillaries are very dilated, you're leaking fluid into the interstitium, or it may mean that you have profound vasoconstriction and now you've got a failure to mobilize your blood volume. And most importantly, the loss of your ability to constrict or dilate your vessels depending on the tissue needs. Now, in order for that to happen, you can't have sepsis, you can't have COVID, you can't have an overdose of vasodilators, you can't have an overdose of vasoconstrictors, and you can't have metabolic acidosis. In metabolic acidosis, a common form of shock will be inadequate vascular tone, represented to you with blood pressure that is not responsive to fluid or vasopressors. So if we look at this in a hemodynamic profile, and there are other kinds of shocks, and I'll talk a little bit about them, but these are the main ones: hypovolemic, cardiogenic, compensated sepsis, which looks a lot like hypovolemic, and decompensated sepsis, which looks a lot like cardiac. All of them share poor capillary flow. When we talk about hypovolemic shock, Hypovolemic shock means you have low total volume. You've hemorrhaged, you've lost your volumes, you've been vomiting for days, you're in DKA, you basically have urinated yourself almost to death. You have a low total volume and a low flow state. And you constrict your arteries to maintain your blood pressure, all by yourself without anything else. Cardiogenic shock, high veno volume, but a low flow state. So arterial hypovolemia and venous hypervolemia. And by the way, you're constricting your arteries to maintain your pressures. Compensated sepsis, high arterial volume, high flow states, but an alteration in the vascular tone and maldistribution, as well as evolving microcoagulation, limiting perfusion in your small vessels. Sounds a little like COVID too, doesn't it? Because they're very similar. And then decompensated sepsis, high venous volume and low flow states. Okay, now look at the difference here in arterial constriction. Vasoconstricted high SVR and hypovolemia. Vasoconstricted and high SVR in cardiogenic shock. Vasodilation and low SVR in compensated sepsis, but in decompensated sepsis, high SVR. And the difference is that in compensated sepsis, you have a high flow, a high stroke volume and a high cardiac output. And in decompensated sepsis, you now have cardiogenic shock. That's so incredibly important because if we can identify patients early, we can actually support them effectively with appropriate therapy designed to treat their problem, not just their symptom. And by the way, all of them share this: metabolic acidosis with mild to severe base deficit, depending on how severe the underlying problem is. So if we have a severe base deficit with severe metabolic acidosis, they're all going to lose vascular tone. None of them will respond to vasopressors in the state of severe metabolic acidosis. As a bedside nurse, from my point of view, this is one of the most important aspects of understanding shock. If you have metabolic acidosis, you need to do whatever you can to make that better so that patients can respond to their own circulating norepinephrine and epinephrine and the exogenous norepinephrine and epinephrine that you're administering. So again, we look at those types of shock. Hypovolemic, most common shock, preload problem. Not enough volume, not enough stretch. Cardiogenic shock. This is a contractility problem from ischemia, from myocardial infarction, depression of the myocardium, stunning of the myocardium, dysrhythmias, or valvular dysfunction. This is a heart problem, and typically it either needs surgical repair of the valves or a positive contractile or positive inotropic agent. Distributive shock is an afterload problem. It is loss of vascular tone, and the heart has to work so hard to fill that dilated vasculature, trying to perfuse appropriately, that you eventually go into cardiac failure. And obstructive shock, which occurs whenever there's something occupying space in the thoracic cage that compresses the heart. Pericardial tamponade, tension pneumothorax, high PEEP on your ventilator, pulmonary embolism, which actually obstructs blood flow out of the right ventricle, and it must leave the right ventricle, go through the lungs to get to the left ventricle. Obstructive shock is both a preload problem and a contractility problem. So, measuring stroke volume, preload and afterload shock is really important. And that brings us to the basics of the Frank-Starling Law. Now, don't let that get worrisome for you. Lots of words on this slide. This is my slide. You can actually investigate hemodynamics even more in depth by going to Barbara McLean Edwards Hemodynamics, and there's a series of 9 programs on hemodynamics, and this is one of the most important slides in that whole program. And that is what Frank-Starling discovered, and if you look at the visual, you'll see on the horizontal the myocardial stretch. The greater the stretch, the better the recoil. So if I stretch my ventricular fibers with volume, I'll have a better recoil. So volume in should improve volume out. That's the Frank-Starling Law. It's not meant to be difficult. It just says fill the ventricle, stretch the fibers, and as long as those fibers are healthy, they will recoil and eject more volume out. So if we think about the Frank-Starling Law, it's basically volume in, which is your filling pressure, should improve volume out, which is your stroke volume. Volume in should improve volume out. Stretch with volume, recoil, and push that volume out. It's a very simple philosophy. So now we want to think about the basic physiologic measures that we can make every day at our patient's bedside. Okay? So first and foremost, CVP, which just requires monitoring of the distal port of your central line. That's the brown lumen. If you have a pulmonary artery catheter, we would typically use pulmonary artery diastolic pressure, and we use CVP as an indicator, not an absolute, an indicator of preload pressure for the right heart, and the PAD as an indicator, not an absolute, of the preload pressure of the left heart. Cardiac output and stroke volume is an index of the volume load and the contractile apparatus to move it forward. We're going to use stroke volume, and our most common is going to be CVP and stroke volume. Systemic vascular resistance, remember, is the calculation requiring MAP, CVP, and cardiac output, which is stroke volume times heart rate. And then, of course, we can do mixed venous gases, which again are beyond our purview here, but we're going to use the base deficit as a basic indicator of tissue perfusion. Our clinical measures at the bedside: hypotension, alterations in stroke volume, anuria progressing to oliguria, increasing creatinine, decreasing urine output, acidosis, metabolic most commonly, and central nervous system dysfunction. So by the way, there are 3 questions you ask every time you're making changes at the bedside, every time you come into the room after report, and every time when you're leaving. The 3 questions you ask. Is there evidence of volume? Is the volume in the right compartment, which is always the arterial bed? And are the tissues perfused? Is there evidence of volume? CVP. Is the volume in the right compartment? Systolic blood pressure and stroke volume. Are the tissues perfused? The base deficit. Everything you need to evaluate shock. 3 simple questions. So in cardiogenic shock, lots of causes: dysrhythmia, mechanical obstruction, regurgitant valves, obstructive valves, loss of myocardium, impaired contractility, poor compliance, which would be hypertrophy or a hypertrophic obstructive cardiomyopathy. So anything that disrupts heart rate, outflow, or contractility. Heart rate, outflow, or contractility causes cardiogenic shock. And typically with that, we're going to see a wedge pressure or PAD up, CVP up, cardiac output down, stroke volume down, the calculated SVR is up, and the patient is going to be acidotic and using lots of the oxygen that's delivered to their tissues, but not enough is delivered. The basic treatment for cardiac dysfunction shock: inotropes, vasodilators, volume, and mechanical circulatory support. So that would be balloon pump, unlikely, Impella, Yippee, and ECMO, which will require a transfer to another hospital because currently we are not doing ECMO at Grady. Mechanical circulatory support. Basically, for us, balloon pump, Impella, transfer for ECMO. So we can see significant failure in the systolic component, which is ejection. That's usually from ischemia and infarct. We see diastolic failure. That's usually related to valvular dysfunction. Could be pericardial tamponade or just pericardial effusions, or actually increased positive pressure or pneumothorax compressing the heart. Okay. So if we look at an inotropic challenge, and we're talking about the Frank-Starling mechanism, again, the horizontal being CVP and the vertical being stroke volume. If I have a patient who has a high CVP and a low stroke volume, I'm going to consider an inotrope. Now, there are other things I might do like diuresis or renal replacement therapy, but just for what we're talking about here, an inotrope. What I'm trying to do with an inotrope is shift the patient to a higher stroke volume. Now the CVP may go up because it's increased ventricular tension when I add an inotrope, but their stroke volume will go up, and that's going to be the best thing for that patient. Hypovolemic shock occurs from two causes, hemorrhagic or non-hemorrhagic. So again, reminding ourselves about non-hemorrhagic, we might be vomiting, diarrhea, dehydration, or we might be actually putting fluid into the extravascular compartment, such as we do with peritonitis, pancreatitis, and ascites. Hypovolemic shock, also known as low preload shock, wedge pressure, PAD, CVP down, cardiac output stroke volume down, SVR calculated is high, patient is using as much oxygen as they can from what's been delivered, but they tend to have significant, especially in hemorrhagic, significant base deficit. And the treatment, of course, volume. Red blood cells if it's hemorrhagic, and surgery. If you're bleeding, you may need surgery. Okay, so we think about hemorrhagic loss and solute loss. Solute loss occurs very clearly in patients who have diabetes insipidus and also in patients who have diabetic ketoacidosis. Now, same thing here. We're going to give you a challenge for your Frank-Starling mechanism, and what we're going to do is give you volume. Even if your CVP goes up, as long as your stroke volume is improving, we're going to give you volume. We're never just going to give you volume. We're going to give you volume and watch what happens to your CVP and your stroke volume, basically using a modified Frank-Starling curve. Okay, so I want to just remind you of the two things we've just talked about. These are the shared circulations, divided right down the middle, oxygenated blood to the left heart out into the system, deoxygenated blood to the right heart up into the pulmonary bed. Okay? Whatever I'm going to give is going to be in the veins. Volume in the veins, central or peripheral. Volume in the vein should always end up with an improved stroke volume. If I'm giving you volume in the vein and the stroke volume isn't improving, I'm going to stop giving you volume. You've got to improve your stroke volume when I've given you veno volumes. If I give you inotrope, and I'm giving that also in the vein, if I give you an inotrope, I need to see that your stroke volume increased. If your stroke volume didn't increase, the inotrope isn't functional at the level it's at. Maybe you need more, maybe you need less. Just like with volume, maybe you need more, maybe you need less. But if I can't improve your arterial stroke volume with these therapies, they're not the right therapies to be applying for that patient. Okay, so as we think about those relationships, we come to the last, which is distributive shock. Now, I find this kind of an appalling, over-distended describer because there are lots of reasons that you have maldistribution. The first reason you have maldistribution, you severed your spinal cord. That's the neurologic factor. The second reason will be anaphylaxis. So spinal cord injury and anaphylaxis, those are pretty easy for us to appreciate and understand. I injured above C5, I've lost vascular tone. I have a histamine release, I've lost vascular tone. So my vessels are dilated and I maldistribute the blood flow. But what I want you to really be thinking about is what happens in sepsis, what happens with profound metabolic acidosis, with kidney failure, and with ketoacidosis. All of those situations etiologically cause a loss of vascular tone. And the most frequent and the worst is metabolic acidosis plus sepsis, metabolic acidosis plus sepsis plus COVID. The worst, causing loss of vascular tone, and now I have myocardial contractility that is struggling to keep up with the blood flow requirements to fill those dilated blood vessels. Oi, this is terrible. This is called low afterload shock. So the CVP wedge PAD may be normal. They may be low, but usually they're pretty normal. But the cardiac output and stroke volume is up. Stroke volume is up. Calculated SVR is down. And because we're not actually distributing into the capillaries, we're maldistributing, the SVO2 ultimately will be normal to high. And the patient will have a profound and profoundly worsening base deficit. So the treatment, of course, treat the cause, right? So if it's diabetic ketoacidosis, treat the diabetic ketoacidosis. If it's sepsis, treat the nidus of infection with antibiotics or surgery or drain. But the basic treatment of the low afterload, after you treat the cause, volume infusion, vasoconstrictors, and considering inotropic agents. But volume and vasopressors first, and then consider inotropic support. So again, sepsis, anaphylaxis, and acute adrenal insufficiency, adrenal crisis, toxic shock, which is a form of anaphylaxis, all can present with low afterload shock. So volume resuscitation, of course, is the cornerstone of hypovolemic and septic shock. Not the cornerstone, of course, of cardiogenic shock, because you may have volume, but you can't move it. So first and foremost, we always want to replete adequate intravascular volume if we have time before we begin vasopressors. Now, we might have to add vasopressors immediately because the patient's blood pressure is so low. We have to add a vasopressor first, try to bring the pressure up to maintain essential organ perfusion, and then we'll start adding fluids. So none of us are going to say in a patient with shock who has a blood pressure of 40, wait, let me give them volume. We're going to give vasopressors, and then we're going to give volume. And as we give volume, we may be able to wean down to off the vasopressors. So we're always going to consider, when we've added vasopressors, we always want to consider that there may be coexisting hypovolemia, and we're always going to consider giving volume while titrating vasopressors. Now remember, patients who have ARDS, patients who have congestive heart failure, so their lungs look wet on chest x-ray, their breath sounds are rattly or almost absent, they may have high CVP or high PAD, we may withhold fluids from those patients in those situations. But if fluid fails or it was never indicated, first we're going to open the book to adrenergic receptors or phosphodiesterase inhibitors for both vasopressors and inotropes. So we know what vasopressors are. They're classes of drug that elevate mean arterial pressure. And they are always indicated when there's been a drop of 30 millimeters of mercury from baseline systole or a MAP of less than 60. And remember, we're always going to think about this in relationship to volume. Inotropes we're going to administer when patients are not volume responsive and their stroke volume is low. We'll always consider an inotrope. Okay, so again, decrease of greater than 30 millimeters from baseline systole or a mean arterial pressure of less than 60, especially when we see end organ dysfunction related to hypoperfusion. So very important. Always remember, hypovolemia must be corrected prior to institution of vasopressors. The principal use of vasopressors and inotropes are really about pathologic maldistribution of blood, pump failure, and again, remember why we apply it. I think it's so important, I say it multiple times. 30 millimeters drop or 20% from baseline systolic blood pressure or a MAP less than 60 with evidence of end organ dysfunction. Volume first, vasopressors next. And we're going to choose our agents based on what we think is wrong with the patient. We'll titrate up. We at the bedside have a lot of opportunity to titrate up, but we want to be gentle as we titrate up, and we want to stop as soon as we've recruited a mean arterial pressure. Very important to understand the guidelines for vasopressor titration as applied at Grady Hospital, that if you reach the maximal dose of your first agent, then a second drug should be added to that first. You need to be aware of whether or not the patient's responding to the medications that you're giving and titrate following the policy of Grady and the policy of the JCH. And very important to appreciate that we are within boundaries during titration of drugs. So I basically say if you started on 2 and now you're 3 times your starting dose, so now you're at 6 or you're at 8 of norepinephrine, you started at 2 and now you're at 8, you need to notify your provider. They don't know you're titrating upwards, and you need to let them know that that's happening because they may choose to add a second agent. And remember, those failure signals to respond indicate need for second therapies. Now, very important when we talk about shock to understand the three basic categories of receptors. Alpha 1, which is adrenergic, beta 1 and 2, adrenergic, and the dopamine receptors. And in today's world, we really don't care much about the dopamine receptors anymore. We are mostly looking at alpha 1 and beta 1. And I, again, want to remind you that it's an incredibly awesome responsibility and an incredible honor of autonomy to be able to titrate drips. But you must observe the limits in the titration policies. They are there not to limit your autonomy, but to protect your patient from overzealous titration of catecholamines, epinephrine, norepinephrine, neosynephrine. All right, so if we look at alpha 1, I always just say alpha 1 artery, alpha 1 artery, affecting the vascular wall, causing vasoconstriction. Now, alpha 1 can also affect the heart, increasing some duration of contraction without increasing the heart rate. Beta 1, for the beta adrenergic, beta 1 actually receptors reside in the sinus node and down in the ventricular myocardium. Beta 1 receptors affect both contractility and heart rate. Now, the beta 1 receptors in the sinus node navy junction are highly responsive to epinephrine and secondly to norepinephrine. And the beta 1 receptors in the myocardium are highly responsive to norepinephrine and secondarily to epinephrine. So really important. Long ago, we talked a lot about dopaminergic receptors. I want you to know that there is still discussion about that, but in general, dopamine is used in moderate dosing between 5 and 10 only for heart failure patients because it promotes some coronary vasodilation at the same time that it promotes vasoconstriction. And at the dose between 5 and 10 mics, it also can enhance contractility. So I'm not going to talk very much about dopamine because I don't really think that that's the most important thing for us to consider because it's used only in specific subsets. So in clinical application for septic shock, first-line agents norepinephrine, second-line agent is vasopressin and epinephrine, and in the neuro intensive care unit or in the OR, the first-line agent may be neosynephrine or phenylephrine. For heart failure, dopamine and dobutamine. For cardiogenic shock, norepinephrine and dobutamine. For anaphylactic shock, epinephrine. For neurogenic shock, neosynephrine. And from severe hypertension induced from anesthesia, neosynephrine. But following open heart surgery, epinephrine. Now that is a big list with a lot of information, and I really appreciate your attention to these details. But it's singularly important for us to appreciate dosing of medication depends on the etiology of shock. For hypovolemic shock, volume, 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 red cells, and if the patient is bleeding, surgery. For cardiogenic shock, inotrope, plus you may need a vasopressor. For heart failure, dopamine, dobutamine, and the phosphodiesterase inhibitor milrinone, which does not affect your heart rate but improves contractility while also causing mild vasodilation. Anaphylaxis, no worries, epinephrine, we knew it, we always knew that, and second-line vasopressin. Neurogenic shock, neosynephrine, anesthesia-induced hypotension, neosynephrine, and following a CABG, epinephrine. Now this isn't all there is to know. We certainly need to understand at a much higher level how do we use vasopressors and inotropes. And in the next series, I'm going to discuss that and how we apply that to our shock states and evaluate whether or not our patients have improved. So remember, single most question, the three important questions. Is there evidence of volume? Is it in the right space? Evidence of volume CVP or wedge or PAD? CVP, PAD. Is it in the right space? Left ventricular stroke volume. And does it achieve tissue perfusion? Base deficit. Those are the three essentials that we have to know when we're talking about shock. volume, right place, tissue perfusion. CVP, stroke volume, base deficit. Thank you so much, and I'll see you soon. Bye-bye.